Today, we're kicking off a powerful new series focused on women's sexual health. Sexual health is often overlooked in midlife, yet it's a vital part of our well being, confidence, and connection. This series will explore the changes, challenges, and possibilities that come with evolving intimacy during perimenopause, menopause, and beyond. For many women, pleasure, comfort, and connection can feel disrupted during this stage, whether due to hormonal changes, painful sex, or simply not recognizing our own evolving desires. To start this conversation, I'm joined by Megan Price, nurse practitioner. She's a board certified family nurse practitioner, Menopause Society Certified Practitioner, and AASECT Certified Sex Counselor. She has spent the past 12 years practicing in community health and currently works as a primary care provider at Neighbor Health in East Boston. 7 years ago, Megan built the sexual wellness specialty at Neighbor Health, combining her expertise in sexual medicine and primary care to address sexual dysfunction and midlife health transitions. In April 2025, Megan opened Mystic Valley Sexual Wellness in Melrose, Massachusetts, offering personalized concierge care for menopause hormone therapy, sexual dysfunction, and couples intimacy counseling. She also provides CME talks to medical providers on female sexual dysfunction, perimenopause, menopause, and hormone therapy. Today, we're diving deep into dyspareunia, or painful sex, and the innovative, empowering therapies she uses to help women heal, including Sensate focus and Vibrator therapy. Whether you're experiencing discomfort, feeling disconnected from pleasure, or just curious about how to support your sexual well-being in this chapter of life, this conversation is for you. This is going to be an empowering, stigma-free space, and you just might walk away with a few new tools to bring more ease, curiosity, and pleasure into your own life. I'm so excited to start this series. I feel like a lot of my listeners have these questions and aren't quite ready to ask them or talk about them openly, so they can pop us in their earbuds or put us on in the car when they're driving alone to work or wherever they may be, and hopefully get some questions asked today.
Yeah, I'm excited too. Thanks for having me.
So what started and drew you to specialize in sexual health and wellness, especially for women?
Yeah, I got pulled into it pretty early in my career. I think I had only been practicing in primary care for 2, maybe 3 years. And I found myself developing these really great relationships with my patients. They would trust me enough at one point to say, you know what, I actually don't want to have sex with my partner. What do I do? Or they would say, I'm 42 and I've never had an orgasm. What do I do? And I was hearing this all the time. And I was just like a deer in headlights because we don't get any of this training in school, right? I know what to do when I think there's an STD. I know what to do, when there's certain irregular bleeding patterns, but otherwise, female pleasure was never something that was talked about. And so I started kind of looking around, seeing if there were some continuing education classes out there that I could take just to give me some sort of tool to be able to give women. And I found the ASEC program through South Shore Sexual Health Center here in Quincy, Mass, just south of Boston. And I met with the directors and I just really fell in love with the whole curriculum. So it was like a year of coursework and then another 3 or 4 years of actual supervision. So it was a lot of work, but it really I felt like I cracked open a completely different part of my brain. And it has been so invaluable in primary care because so many women deal with this. I see men too over in primary care, but women is really where my heart is, and that's what I do in private practice right now.
Well, and for men, the male orgasm has not been the enigma
Exactly.
that the female orgasm is. Like, let's be honest.
Yeah, they don't need quite as, and they're just taken more seriously, and I think it's also something I always hesitate to bring up statistics that I haven't double checked, but I believe it. It was something like when men have an issue with their orgasms, the average time from like the problem to bringing it up to a medical provider is like 2 weeks. I mean, it's insane. And then for women, it's something like 6 years, which makes sense because it's something that I think there's a lot of internal kind of beliefs and value systems out there that do not talk about female pleasure as something that is valuable or something that's even worth bringing up. So in medical practice, we're so focused on pain, right? We're always asking about pain, but nobody's asking, okay, but is sex pleasurable? Do you like it? Are you having fun? Are you having orgasms? And when I started asking those questions, just in a typical physical or during their pap smear, women were just kind of like, God, I don't know. Nobody's ever
Nobody's
asked me
asked me
that.
that.
Yeah, I haven't thought about it, And so it started getting really fun talking to a lot of women.
Well, and I feel like that's the fact that you ask that on a standard exam, just as a question in general, is something that you don't see happen for a lot of women. And if they're not being asked, they don't feel comfortable yet to bring it up. So the fact that you're doing that for them is huge.
Yeah, I think it's important. It's the same way that, every time you go in, somebody's asking you probably about, do you feel safe at home? Or how much do you drink a week? Illicit drugs did you do last week? We phrase those in a way that really tries to take away any kind of judgment and shame. So if it's being asked to everybody every time, you're not like, are they judging me? Do they think I'm the type of person who would be doing that? Or if you're just bringing it up every single visit, then it starts to become normal, and it starts to be okay to talk about it. Every question is essentially giving permission. Every time we ask it, we're giving them permission to talk to us about it. And so I think that that's really important.
And so now that you've opened your own sexual wellness clinic, what prompted that for you? What was that point where you were like, you know what, I could actually make this something of its own?
I think it was a combination of things. I hit burnout pretty hard because I've been in primary care for 12 years now. I was doing it full time with two young kids. And yeah, everyone hits burnout at some point. And when I hit it, I think a lot of it had to do with I have all of this great training in Sensate focus and in low libido and menopause. But asking me to do that in 10 minutes is just impossible. And the majority of my patients at my clinic do not speak English. So I'm also using an interpreter, which doubles the amount of time it takes to do anything, And so I just found myself feeling like I wasn't providing the kind of care that I could give and that I really felt women deserve. And so, that in combination of just wanting to be around with my kids more, I said, well, what would it look like if I could design, a space where I could do this kind of care really well for women? And that's kind of, just the way my brain works. Once it started going, 6 months later, we were opening our doors. So
That's amazing. That's amazing. So, what are the most common causes of painful intercourse with perimenopausal and menopausal women?
I think in the perimenopause, menopause stages, dryness is absolutely the most common. Even if it's not the primary, it's definitely influencing things because as we enter through midlife and we start to see these hormone changes that happen in perimenopause, our body's just not as efficient at lubricating itself well. And we might even have, if our estrogen levels are dropping low enough, often enough in perimenopause and then definitely postmenopause, we just develop vaginal dryness. That tissue gets thinner, it gets more fragile. And, the combination of that, the lubrication plus just the baseline dryness, really makes sex uncomfortable. And so, one of the things I like to ask in terms of pain with sex is, okay, where is this pain? If we can really localize it. And that's great if we're already doing a pelvic exam, they can show me exactly. But if we're just talking, is it insertional? So if we're talking penetrative sex, is it right at the insertion site, right at the opening of the vagina? Burning at the introitus about that opening is very common and can persist for hours after sex. That's a good indicator to me that there's something going on superficially in the skin or some dryness. Or is there pain with thrust? Is there pain kind of farther back? That could be cervical sensitivity. That could be endometriosis, adenomyosis. There's all kinds of things that might trigger us to get like a pelvic ultrasound or something like that. But you really need to ask a lot of questions and you need to ask them like in 5 different ways over and over to really get a good picture of what's going on. And ultimately, this is why I really opted to do a brick and mortar in private practice other than telehealth, because you need to do a pelvic exam. You need to do a bimanual. You need to see what the uterus feels like, what the ovaries feel like, where are they having pain? What does the muscle feel like? Is there tension? I'm really lucky. Just upstairs from me is a pelvic floor physical therapy office. So we work together a lot. We share a lot of patients because a lot of times we also need to get them involved to figure out what's going on.
I did a CE for nurses, a lunch and learn about perimenopause. And one of the things I said is if you don't have at least one good pelvic floor therapist on your Rolodex, like you need to get one. It's
Mm-hmm.
just they can make or break women's lives, especially.
Yeah, and I used to only see them really as something you send women to postpartum if they're having urinary leakage, right? I had no clue until I started going through all of this training, just the scope, how much they can do, especially when it comes to pain or discomfort with sex. It's really incredible.
So I think one of the things for women is a lot of times we get all up in our heads about sex.
Yeah.
There's a lot of psychological issues around, the stigma of sex, the discomfort. There's emotional things that come into sex. So, what do you do to differentiate between the physical causes and the psychological contributors?
I you know, I understand like the desire to really differentiate. I actually don't think it's as important as we make it out to be because the majority of the time we're talking multiple factors that are overlapping. So I always kind of go into a situation assuming that we are going to find physical factors as well as psychogenic factors, right? We do the biopsychosocial model. So we're looking at what's going on in the relationship, if there is one, what is your history, right? What is your religious background? What are your personal values and kind of beliefs about gender and sexuality and your own connection with your body and your pleasure, as well as the physical? Because sometimes we can kind of get fixated on the burning that they're experiencing with friction and not realize that, you know, there's also this hesitation and this shame because maybe they grew up thinking that pleasure was sinful. And so you really need to kind of address everything and just assume that you're going to be finding things even as you go. Because sometimes once we remove the pain from sex, we're still dealing with low libido or poor arousal because of those kind of emotional psychologic things that's blocking arousal. So it's tricky. There's not an easy way to do it. And I think if you just go in with an open mind and curiosity, like you'll start to see those things.
I see why a specialization in this is important because it's way more than just something you can cover in 10 minutes.
Yeah, no, it's impossible. You can't. And that's what's so frustrating is because, every woman I see, I totally understand how much it took just to get them in the room to feel comfortable telling me whatever they're telling me, right? That could have been a 6 month, could have been a 2-year journey just to get there. And so for me to kind of rush through it feels terrible. But you also have somebody in the next room who's waiting for you. And so it is such a terrible tension. It's really terrible what we've done to providers and to patients in the medical system right now. But that's why like having 90 minutes with patients in private practice is it's just invaluable.
Yeah. And I was really interested in the Sensate therapy and the Sensate focus and vibration therapy, vibrator therapy, sorry, specifically because those are things I'd never heard of before. And so I really want to get into the Sensate focus therapy right now. Can you kind of explain what that is and where this technique comes from?
Yes, I love Sensate Focus. So Sensate Focus is a series. It's very structured. It's a series of exercises that were first developed by Masters and Johnson. They're kind of like the parental figures of sex therapy. I think there was an HBO series about them or something. I think it's from the 90s. And over the decades, it's definitely been refined. And everyone still, every practitioner kind of puts their own spin on it. But it essentially is a series of exercises that is typically done with couples. I actually do it with individuals as well. Typically done with couples to really try to retrain the brain to not think of sex as something that is pressured or anxiety inducing, but something that is, pleasurable and something that your body is worth craving, right? So I talk a lot about with low libido, if your nervous system has learned that sex is painful or it causes anxiety or it's not pleasurable, you kind of dissociate. A lot of women will say they feel numb, right? Why is your body going to crave that? Right?
Yeah.
Why are we so surprised that we don't have a high libido all the time when it's not something we like, right? That's not how our nervous system works. It's too smart for that. And so this really helps kind of retrain the brain. And the founding principle of Sensate Focus is this idea of touch for the self versus touch for your partner. And this is where I can really start to lose people because it sounds very counterintuitive. But when we focus too much on what our partner is experiencing, okay, so we use this language of, oh, I give my partner their orgasm, right? When we do that, our own sexuality just is so outward focused. It's so external. And we're not paying attention to what we are experiencing during sex, right? And so what happens then is that we become really dissociated during sex of what we are experiencing, our own sexuality. And when you have two people doing that, when you have two people kind of focusing on the other person, be like, are they enjoying this? Do they like this? Do they want me to change something? Do they want me to do something else? Who's having fun here? Right?
Like, that's exhausting. Exactly.
Right? Like nobody is paying attention to what they're experiencing. So how could you be feeling pleasure other than just the typical physiologic response of like engorgement, orgasm, whatever? Pleasure's deeper than that. Pleasure's not just orgasm. And so what Sensate Focus does is it kind of flips the script a little bit, and we say, you are in charge of your pleasure. You are in charge of your orgasm. You are not responsible for your partner's orgasm. And again, that sounds really selfish, right?
Yeah, but that sounds really nice because I feel like we carry the load of everything for everyone all the time. It's nice to think during sex, I get to think about myself.
Yes. That's a great reframe. That's such a great way to think about it. And what we've seen, again, we have decades of research on this, is this kind of paradoxical response where when both people are focused on their own pleasure, we're not saying you're ignoring your partner.
Yeah.
But when you're focused on what you're experiencing, the satisfaction and the pleasure for both parties actually increases, especially over time. And so it's such a cool therapy, and it's such a fun process to walk through with patients, especially couples, because a lot of times they're coming to me for this after long periods of sexlessness, for whatever reason. It doesn't always need to be something as disruptive as like infidelity. Sometimes it could be as banal as just two small kids at home, and then a year goes by and hey, we haven't had sex. And then it just starts to feel awkward trying to do it again,
Yeah. Well, and there's a lot of body changes that come throughout life. And so those kind of things can kind of put a damper on it. And you do kind of get in the mud of parenting and lifing. And so I can see that being a reason. So how do you introduce it to your patients, especially those that are like a little anxious, feeling disconnected? How do you approach this focus therapy?
It kind of depends. So a lot of times what will happen is I'll have an individual coming to me, not a couple together. In private practice, couples can come see me specifically for this, and so that's easy. But when it's an individual, I might introduce it as not exercises as a couple, but exercises on an individual level. And this is really, really great for anybody with a history of sexual trauma. Because again, our nervous system has learned like sex is something to be feared, right? We go into that fight or flight response. Maybe we even have vaginismus, where the outer third musculature of our vagina actually like just tightens so much that we can't have any kind of penetrative sex. That happens a lot, especially in younger women who have had trauma or who maybe grew up in kind of a sexually repressive home or religious background. And so I'll introduce it as, going through, I talk to them about their nervous system. I talk to them about this idea of being able to experience touch and sensation fully without dissociating, without thinking about something else, just to get through it, right? And so I introduce it as self-touch exercises, and we go very, very slow. And I tell them, again, it's giving permission, right? A lot of women who have no history of self-touch or self-stimulation, giving them permission to do it, they are interested, and they are on board. And so we'll start with touch to erogenous zones kind of over the clothes, and we might do some body mapping. So color in the parts that are red, yellow, green, based on how comfortable you are with touch there. What comes up for you when you're touching these areas? And that can give us a lot of information and can really help me figure out if they're even somebody who's ready to do couples work. Because if there's a strong history of trauma, if there's a strong history of something like vaginismus, then starting couples work right away might be too much, So it's different for every person. Again, that's why it takes a lot of time. You need to know who's in front of you. You can't just hand them a handout on how to do Sensate Focus and send them home. Okay, that's kind of irresponsible. But a lot of times I'm introducing it as just self-touch exercises to kind of ease them into it.
Yeah, and I don't know about upcoming generations, but I feel like our generation and back, the idea of women touching themselves, it's just we just don't talk about it. We don't talk
Mhm.
about any form of self-pleasure. It's taboo. So to be getting permission from your clinician to say, this is your homework.
Yeah.
Go home and work on this. It's not a bad thing. Maybe we should add this to like an annual exam for all.
We should. And I know we're going to talk about vibratory therapy, but I really, I try, and the language I use is very purposeful. I really try to get away from the stigma of any self-touch vibratory therapy being purely associated with sex and orgasm, right? So I use the term self-touch and self-stimulation. I don't say masturbation. Okay, I say that, this vibrator is a medical device, right? And I'm instructing you on how to use it. And our goal is not orgasm. Our goal is stimulation of those tissues, right? Because we have so much kind of social feeling about women touching themselves. Like women, if we tell women sex is supposed to be pleasurable, what will happen, right? It's so scary.
Yeah. They might actually expect sex to be pleasurable.
Yeah, and we, that's how it is with sexual education, right? When we talk to women about young girls about sex, nobody's talking about pleasure. And so then what happens? What are we telling young girls? We're telling them, oh, sex is going to be painful. Just expect it. That's fine. And again, that's something that can trigger vaginismus. If you're clenched and you're scared your first time and that's your first sexual experience, how do we expect women to just kind of relax and enjoy themselves after that? No, our nervous system remembers that. And so it clenches the next time and the next time, and it becomes this negative feedback.
Yeah, I mean, I was basically expecting to get pregnant the minute I had sex. Like it was such a fearful thing put in my head for me personally that it wasn't something that sounded fun or exploratory. It sounded terrifying.
Mm-hmm. Yeah. And again, like you only know, like I remember I associated sex with STDs and pregnancy, right? It's just
Yeah.
fear-based,
Yeah. Yeah.
right? And so it's like, well, why would I even want to have sex?
Yeah.
Because
Yeah.
like why are people on TV so into this, And
Well, I know.
and you think, oh, it must be because it's really good for men. For men it
Hmm.
feels good. For women it's just what you do, which
Yes,
is
it's what we
awful.
do in a relationship with a man to make them happy, satisfied, work harder, faster, whatever. All
Mm-hmm.
the things. It was a service. It wasn't something for ourselves. Yeah. So you mentioned vibrator, so I do want to get onto vibrator therapy because I think that that's another thing that we were taught we shouldn't think about or look at. And I remember I was in college when Sex and the City, the original series, was coming out every week on HBO. And my roommate and I in college would that was our night. We would have fudge and watch Sex and the City together.
I
And
love
it
that.
felt like Samantha's character was so risque and almost inappropriate. And I remember the episode where she had the neck massager from Sharper Image. And I thought to myself, first of all, is that really what a vibrator is like? But also
Yeah.
the fact that she would be doing something like that on television for her own self enjoyment just felt really uncomfortable for me. So I'm excited to talk about vibrator therapy. And so how do you approach that with a patient?
So it kind of depends where somebody's at in their life. So post menopause, just as I recommend vaginal local estrogen to every woman post menopause, I recommend vibratory therapy for every woman post menopause for the same reasons. So we have really great data showing that vibratory sensation specifically to the outer genitalia, so we're not talking internally, just outer genitalia, that 10 minutes 3 times a week can improve natural lubrication, can improve sensitivity and sensation during sex, and can improve frequency and intensity of orgasms. So why not? And again, we're not talking about penetrative vibrators that you do it until you reach orgasm, right? We're just talking 10 minutes, applying it to the outer tissues before you go to bed at night, right? And if you go to orgasm, great, fantastic. little treat. But that's not the purpose. The purpose is really, it's like physical therapy. We are stimulating tissues, we're encouraging blood flow, we're encouraging circulation, and we're really trying to prevent the architecture of our pleasure anatomy from changing as drastically as it can post-menopause. Pre-menopause, a lot of times I'm introducing vibratory therapy for other kinds of sexual dysfunction. So low libido, difficulty with arousal. Again, trying to get more information. So what parts of your body can lead to an orgasm and arousal? What parts don't? A lot of women will complain of numbness, like I mentioned. So is it really numbness? What happens when we add vibration to the equation here? And yeah, there's a lot of stigma around it, but I think there's also stigma in the sense that a lot of women are worried, what is my partner going to think when I bring home a vibrator? And so I often have to do a lot of this education around, this is not replacing your partner. Your partner does not need to be intimidated by this device, right? We're trying to enhance what it's like being with your partner by using this device, And if I can get the partner involved to use it, then great. That can be fun too, but that can take a few more visits sometimes.
A little bit more work around that. Well, when you were saying that, I was like, oh, this is like strength training. Like it doesn't need to
Yes.
be 5 days a week for an hour every day. So the same thing, just it sounds like a few days a week, 10 minutes a day. And it doesn't necessarily need to achieve anything. It's just kind of laying the foundation for better orgasms down the road with your partner or by yourself.
Yeah. I think about, all the massage guns people use now on their muscles post-workout. It's the same idea. Why are we doing that? We're doing that to help stimulate blood flow to those areas,
That's a great way to look at it and completely take away the stigma of what a vibrator is.
Yeah. And so that's why in my practice, I have a lot of outer vibratory devices so that they're not scary. They're not phallic. I'm really trying to emphasize that we can do this in a way that is just outer, and we're completely removing kind of the cultural idea of sexuality from it. I still think this is a big part of our sexuality, but again, everyone has a different view of it. And so I really try to take away any stigma that might be there.
Well, because I don't know, when I think my first instinct is to go to a sex shop or porn. Like those are the two directions I go when I think of the things we're discussing. And that's not even at all what this is.
No. Yeah. And that's the hurdle I have to get through. I mean, imagine I'm doing this in like a federally funded health center, so I'm constantly just like, oh gosh, wait until HR like really finds out. But it is like, I'm always reassured by how much data I have to back all of this up. I mean, we know that this stuff helps, that it helps women. It helps even women who aren't sexually active. I've walked them through vibratory therapy because it just feels good to be connected to your own sexuality, right? Sexuality does not mean you are actively having sex. Sexuality is this whole kind of inner schema of your identity. And to feel connected to that, I think is really important. Not just, well, we're having pleasurable, painless sex, right? It goes beyond that.
Yeah. Well, personally, I feel like when I have been able to step back and take time to find pleasure in things, all things, everything in life feels better, easier, more connected. And so it's not just necessarily I want to have an orgasm or I want to enjoy sex, but it's just finding pleasure in all of life.
Yeah, absolutely. I mean, we talk all the time about just self-care, right? Taking time for yourself, and that can look 1,000 different ways depending on the person. And I very much see this as self-care. You're caring for your self-esteem, you're caring for your sense of identity, your sense of self-worth. We like to think that sexuality is separate from that, and I think it's like foundational.
So what kind of vibrators, you're talking about external versus internal, what kind of tools or what types of vibrators or tools do you typically recommend for external? Because I know there's different kinds and they do different things.
Yeah, so I'm not too picky. I like ones that are silicone grade, like medical grade silicone, because they're very good for your body. I get kind of nervous with anything like plastic, obviously. I like them for you to have some control over the intensity of vibration. So a lot of them will have different vibration. I think that's really important, especially when we're introducing this for the first time, maybe post-cancer treatments, maybe because of pain or trauma. Starting at a low level and then having your own ability to increase it is important. And yeah, and it's okay if it is an internal device. We can still use those. I really just try and get a sense of what the patient's comfortable with. I have some women who are like, yeah, give me one of each. I am here. I'm ready. Like,
Yeah.
I want to try them all. And then I have women who are really, really hesitant. And so I have like a little bullet one that's so tiny and it's round and it almost looks like a chapstick. Right?
Okay.
So it's not scary. You can leave it on your end table, and if somebody happens to see it, fine. And we're just using it, maybe even just a minute a week, just to get a sense of what it feels like to use it. So there's a wide variety out there, and I don't think there's any that are especially wrong. But I like them to be safe, silicone, soft, and then just have some flexibility over the intensity.
Okay. I'm thinking back to when I was in pharmacy school. If she hears this, she'll know I'm talking about her, but I hope nobody else will. But I had a girlfriend who was moving, and her boyfriend's family was helping, and she called me, and she was like, "Quickly, go to my nightstand, go to this drawer under these clothes, grab it, put it in a box, hide it for me." And so I think normalizing. Hopefully, she's not like, "Oh my God, she's outed me." Nobody will know who I'm talking about. But I remember just like the panic of what would we do if somebody finds it, and changing that conversation to, I have teenage daughters that at some point will be women, and I hope that when they are this age, they are way more comfortable having these conversations and devices in their life, because why would you not want that for someone you love?
Yeah. And I think it is hard. I mean, I have a young daughter and I think about the conversations I'll have with her in the future, and it's very different, like kind of like the Instagram versus real life, right? I have my ideal, like, me being like a with it sex counselor, the kind of conversations I'll have with her versus what I might actually say in real life. Right?
Mm-hmm.
There's
Oh
that
yeah.
tension for me too, right? Even though I believe all of this and I talk about this all the time. Oh my gosh, my own daughter, who I never, right now, I'm like, I can never think of her as a sexual being,
Yeah.
right? I mean,
Yeah.
I think it's hard, and it's not to say it's easy, but yeah, I think starting to incorporate these things as if they are just normal parts of being a woman, I think is the first place to start, you know?
Yeah. Oh, absolutely. Mine are 14 and 16 now, so we're a little bit farther into the uncomfortable conversations that come with growing up. But I do remember, just as they got older, the questions that came, I knew I needed to be open and honest when they would ask, because I remember what it felt like growing up to not know what was going on in my body. And so, but I still remember eating chili, like, huh? Like, you just asked me what? I remember the bowl I was holding, and I was like, oh, okay, reduce the stigma, make them feel comfortable. Like, I had this whole internal dialogue with myself of like how to approach this the correct way, because it is easy to just like shut it down and be like, oh, the stork brings babies and you don't need to worry about that till you're older. But that does help, I'm hoping, remove the shame and empower the next generation. Which is how I'm going to segue into my next question, is that I feel like our generation is still really embarrassed and shamed about sex. We're just starting to come to having conversations about hot flashes and hormonal changes.
Yeah.
So how can we help women, or how do you help women shift that narrative from that shame and embarrassment?
That's a really good question. I mean, I hope I am doing that.
Yeah.
Just by being present, and I like putting, it's hard on social media because that's where I do a lot of my education.
Mm-hmm.
And, we can't use a lot of basic terminology or our videos get flagged, right? Or we could
Yeah.
get
You
kicked
can't say
off.
vulva on
Yeah.
social media.
I just did a whole thing because it's Say Vagina Month.
Mm-hmm.
And so I just did a whole video about saying the word vagina and how ridiculous it is that we have to say all these other little stupid names for it to get around. And it's hard because that's where so many women are getting their information right now, because they're not getting it in their doctor's offices most of the time, right? And so it's weird that menopause is kind of having this like renaissance that's really fun to be a part of. I'm a menopause specialist, so I'm enjoying that. But I am not doing as much talk about sexual wellness and libido and lubrication and orgasm because I can't, because I'm being censored,
Yeah.
So, I mean, it's hard. I think we need to try. I do as many CMEs as I can with other primary care providers to get them comfortable at least asking the questions. Like there is this fear of medical providers. You don't want to ask a question that you're not going to be able to do anything with the answer, right? So if I ask about pleasure and the woman's like, no, and then I'm like, oh, okay.
Yeah. That's tough for
Sorry,
you.
I don't have anything to say.
Yeah. Just a part of getting older.
Yeah. Ugh. So like I get that. And so I'm trying to do as much education for other medical providers as possible to give them some tools to be able to talk to women about this. But yeah, I mean, I think it's going to take a huge cultural shift, to be able to talk about these things without stigma, without shame. And I think that that's compounded by the fact that we're doing so much now over Zoom. We're not doing as much stuff in person. And so we all talk with our girlfriends differently when it's a group of three of us versus texting, right? And so I don't know. That's a really good question. It's one I think about a lot. I don't know how we kind of turn the tide on this other than just really trying to talk about it in spaces like this where there is no censorship, right? Or I don't know. Is there?
No, we'll get an E. I'm sure we'll get an E on Spotify and Apple, but that's fine.
Yeah, where you just have freedom to talk about it, and I'm trying to do that too in my community with my private practice, being present with more things, doing more talks that are free and open to the public, just even get some of the language out there, I think is important.
Yeah, I'm not sure if Instagram or, well, all social media really, having to use like SEGGS
I hate that
for sex
so much.
Do you know how embarrassing? And then you get comments like, if you can't type it, why are you talking about it? And it's like, it's really, I would love to talk about it and I would love to, spell it correctly, but I have to use these silly words so that people don't, flag me or I get shadow banned.
Yeah,
it's nonsense.
I hate it so much because it just feeds into this idea that it needs to be under wraps, right? That it's not something that's safe to talk about.
Yeah. It's frustrating. Maybe someday we'll figure out, because I feel like there's this delicate balance between explicit content that people should be protected from on social media and on the internet and clinical scientific conversations about anatomy and physiology. I mean, they're smart enough to like give us ads specifically based on what we look at and what we talk about. Mm-hmm. Why can't they figure out a way to differentiate between this is clinical information we want women to have versus this is explicit, inappropriate, pornographic content we shouldn't have on our platforms?
Yeah. One of the things that I treat anorgasmia. So women who have either lost the ability of orgasm, maybe they never had it to begin with, they've never had an orgasm. I point them to the website OMG Yes. Are you familiar with this?
Yes.
It's fantastic. I think it's in a lot of different languages. There's all different types of bodies, abilities, and it's basically women instructing other women this is how I feel pleasure, and instructing on kind of self-touch techniques and a lot of different things. And I recommend that to patients and I say, like, this is sexually explicit, but it is not pornographic, even just like putting a boundary between that and saying like, we can look at videos of our bodies, of women doing instruction on their bodies, and we can separate that from porn, right? Like that's not pornographic. This is like, we need to teach each other how to do these things. And I've had so many women who have had their first orgasms from learning something from those videos, right? And so it is this very interesting idea of we umbrella everything under this is pornographic, this is inappropriate. And so what do we have? We have a bunch of women who don't understand how their bodies work and don't even know how to talk about it. It's a shame.
I know. I'm going to beat my head against my desk right now. Another thing I feel like women, we're still getting over that, like, this is just a part of aging. You hit menopause, you literally shrivel up and die. Yeah. How are you helping women to fight that narrative?
I think women, for the most part, like, again, it's the permission, right? Like, oh, I'm 55. Why are you asking me about sexual pleasure? Oh, well, it's because, I think you probably have a lot of life left and you probably want to live another few decades at least, right? And they're like, oh, yeah, I have all these plans to travel and do that. And I'm like, okay, so thinking about that, like, what do you see yourself sexually in the next 10 years? Do you want to still be having sex in 5 or 10 years? Sometimes they're like, no. And I'm like, okay, that's fine. That's not a priority to you. That's fine. And they're like, well, yeah, I guess so. And I'm like, okay, well, if we want, the reality is that your body's going to change. Without hormones, this is what happens. Even with hormones, this is what happens. So if we want sex to continue to be a part of your life and we want it to be pleasurable, what can we do to really support that? Okay, same thing. You want healthy bones for the rest of your life? Okay, what can we do to support that? And really treating it like it is a part of the body, yes, but it is also something that, again, is really important to our sense of self and our sexual schema. So, yeah, I don't know if that answered your question specifically.
Yeah.
I got
Well,
sidetracked a little bit.
But I also you wonder the women who aren't interested in having sex beyond, it's like, well, is that really not something like you've had great, pleasurable sexual encounters and you're okay not having that anymore? Or is it that you've never really experienced a wonderful, pleasurable experience and it's something you want to continue having?
Yeah, no, that's a hard, I always catch myself because it's always important to me that I'm not putting my own values on somebody else, right? Like my own values is, yeah, I want to be having pleasurable sex until I'm wheeled out of the nursing home. Yeah,
Yeah.
like, so, but the reality is that might not be somebody else's value. And there is an instinct for me to be like, well, that's just because they don't believe it. They don't believe that they can experience it, or they never have experienced it. Why wouldn't you want this forever? And I have to kind of take a step back and say, like, well, I can only work with what a patient is willing to give me right now. And it's not appropriate for me to assume that something should be a value to them. And so again, it's that I'm just going to keep asking, at least on an annual basis. Hey, at our last visit, you mentioned that sex wasn't a priority to you. How has the last year been? Have you had sex? What did it feel like? Any thoughts on the next few years? And sometimes, again, the more they start to think about it, they're like, you keep asking me about this. I guess, yeah, maybe I would, and they want to talk about it more. Or they just say, no, not interested. That's just not my life. And that's fine. The same reason why some women are just like, again, I will be on hormones until I die. And I have some women with zero interest, and there's a part of me that's like, no, but don't you know it could be so great?
Yeah.
But at the end of the day, I care more about autonomy and a woman's right to do what she wants with her body. So if that's her choice and that's her value, then great.
Yeah. I was thinking back to when I was in pharmacy school and we were learning about STIs in nursing homes, and I was like totally icked out. And now I'm like, yes, like we need to educate. It's not appropriate. You should not be getting STIs, but there's a reason you're getting them. And that's not a bad thing.
Yes, exactly. Another reason we should be giving local vaginal estrogen in nursing homes, right?
Oh, yeah.
And not just to prevent UTIs and pain, but because sex is happening in nursing homes.
Yeah, it is. Yeah.
Yeah. We have so many ideas about sexuality, and it's like, from 25 to 40, and then it's over, and it's not important anymore. Like those are the years where it's appropriate to be sexually active and enjoying it. After that, like whatever. And
which is so funny because yes, we're done with our procreation phase at that point, but this is the time of my life where I don't have the body shame and the feeling of like all the stigma or just the feelings of self-consciousness now than I had back then. So why would I think that now is the end of my sexual life,
Yes. Victoria, you just hit on like one of my soapboxes. Like I really feel like I want to flip the script of midlife is a time where your sexual functioning goes down. Like I think it should be the opposite because we are so much more confident in midlife, right? Because our bodies are changing, yes. Like everybody's upset because we have weight, but it's so different than when you were 22, right?
Yeah.
And you were so consumed with what other people thought about you and how you looked. And I think that there's a freedom that happens in midlife where that is just shed and you're like, I do not care what other people think. This is who I am. I am coming into myself. And there's some really bothersome symptoms that can come with that, but like give me some hormones and I'm just going to like be me 2.0. Like I am ready, you know? And I think that like that can be really exciting from a sexual perspective if you have kind of the right hype girl, which I like to think myself as everybody's hype girl. So,
Oh yeah, well, and I'm trying to think of how I'm going to say this. So I'll go this way first, but one of the things that I read somewhere is that when we stop desiring a mate to procreate in our like animal being, we stop worrying about pleasing that direction, like finding the mate to mate with and make a baby with. That's when we start actually really enjoying ourselves, because and so there's part of those hormones involved in that, the change in our hormonal shift, that we're no longer out in the world to continue a species, but now we're doing it for fun.
that makes a lot of sense.
Right?
That makes a lot of sense. Yeah.
Yeah. And if we can drop the worry about the other person enjoying it, and we can just all have not choreographed, messy, goofy, sometimes maybe even a little embarrassing, encounters with each other, we could probably solve a lot of world peace problems.
No, seriously. Yeah. Because like none of this pent up energy, right?
Yeah.
Sex and self touch are so great just for stress, for endorphin release. I have a friend who's a sex therapist over in Germany, and he just published a great article last year on chronic pain and self touch. So they found that women who are regularly participating in self touch to orgasm, in this case, had markedly different chronic pain levels compared to like placebo group, which in this case, placebo group, just non-touch group, right?
Yeah.
So, I mean, that's incredible. I mean, think about how much medication we pump into people to treat chronic pain, right? But we don't want to tell them like, hey,
I like that prescription a whole lot better.
I mean, it's so fascinating. It really is this untapped area. I think we have so much of treatment. We have a lot of the treatments for chronic conditions already kind of in us. I'm not anti-medicine at all. That's not what I'm saying. Yeah. But we just have so much like untapped potential in our own bodies and in our own minds. And yeah, I read his study and I was just like, oh my gosh, that's so cool.
So we could take care of the opioid crisis too at the same time.
It would be wonderful.
People are less stressed. They're connecting with each other better.
Yeah, I mean, and I think a lot of girls kind of learn this growing up, right? I had a lot of friends who would masturbate to help with period pain, which makes a lot of sense.
Yeah.
Yeah. It's cool. I love what I do so much.
Yeah, we're just getting into it too. And I think that there's a lot of things that we're learning about the nervous system. Even in pharmacy school, we never discussed nervous system regulation or anything about our nervous system, but understanding how it's connected to a lot of our disease states, a lot of our, mental issues, physical ailments, a lot of it has to do with our nervous system. And if we're taking care of our nervous system, which is part of self-pleasure, it's your nervous system. So, if we're thinking from a holistic standpoint, this is something we should all just be doing, strength training. That's my end point.
Exactly. I mean, I sell it to people. I'm like, this is like physical therapy for your vulva. It's just like any other part of the body. Yeah. I do that with men too. When I do like arousal awareness training for men to help with things like rapid ejaculation. And it's funny trying to differentiate masturbation from self-touch with them. It's women get it, and men, it takes a lot of visits. If they even come back to see me, a lot of times they are not buying what I'm selling. Yeah, it's women intuitively kind of get this, I think, on a different level, because again, we don't really have that kind of base of sex is supposed to be pleasurable, right?
Yeah.
We've had to learn about sex as something else.
Yeah. Well, I think I just figured out my carousel cover for a carousel on this episode is going to be, self-touch is physical therapy for your vulva.
Yes,
Check the arrow.
it is. Yes.
That's my
Arousal
favorite
awareness
quote.
training.
That's wonderful. So, if in leaving this conversation, what is one thing you're really hopeful for the future of sexual wellness and education? We'll stick with the midlife population because that's really who's listening to this. The 20-year-olds will figure it out in a few years themselves. But for the audience, what's something that you're hopeful for?
I hope that it becomes a standard part of midlife care, the same way, like, again, menopause is having its renaissance right now, right? Hormone therapy is being talked about so much. And I want sexual wellness to be a part of that conversation because, I see it all the time. Women come in and they want testosterone, right? Because they've been told testosterone is going to fix their libido. And, 50% of the time, yeah, sure, it does. But 50% of the time, it does not. And so then I see all these providers who are kind of like, what do I do now? And I think incorporating this training into menopause comprehensive training for providers is going to be so important. Like, I want more medical providers to know about Sensate Focus and to learn how to do it. I want vibrators to be for sale or as a part of a package for every single private menopause practice there is, right?
Yeah.
It should be. The same way we are talking about local vaginal estrogen being over the counter, being for everybody. Vibrators are they're being taken out of pharmacies in some states, right? Because they're pornographic. I mean, it's
Let's not step backwards, please.
I know we need to change this conversation, and it needs to just be part of midlife care. It needs to
Your
be a
holistic
pillar.
wellness plan. Yeah. Absolutely. I agree. I was talking with a friend of mine who's a physician, and we have this like pipe dream of a brick and mortar wellness center here, and what we would have, and we talked about nutrition and yoga and stress mitigation techniques, all the things. We should just have like a wall of different vibrators when you walk in the door. All sorts of pretty colors. We'll get them covered on your flex spending account.
Yeah, call it a medical device and get that FSA money. Yeah.
Yeah, for sure. Seriously. Ooh, light bulbs are going off. Thank you.
I'm excited. You should do it. I love this work, and I'm trying to put together maybe like a CME for Sensate Focus for medical providers. It's hard to get people on board with why this is important and how it can transform your practice,
Yeah.
Maybe someday.
I've got so many light bulbs going off in my head right now. Like, oh, the things we could do.
Yeah.
All right. Well, thank you so much, Megan, for coming on and talking about this. And I will make sure in the show notes we have links to where to find you and your practice and Sensate Focus. And we can put some links to websites for women to check out that are non-pornographic, beautiful clinical websites to learn about how to use their, how to promote pleasure and wellness in their own bodies. So thank you so much for coming.
Thank you for having me. This was so fun.
This is exciting. Okay.